Namaste and welcome to our monthly webcast. This is the safest form of greeting I can tell you without doubt. This is a unique moment in history, absolutely unprecedented. As I drove to the hospital this morning, it did strike me how much everything has changed in the last just 4 weeks. And I'm sure in the next 4 weeks things will calm down, and of course, this too shall pass. However, it did not fail to strike me that this is an unprecedented moment in history when physicians are going to have an absolutely unique role. And I think the outcome of the present crisis is going to depend so much on how physicians perform as a community and help us get back together. I also think it's very important to watch our own health as we are exposed, being in the front lines of the greatest chances of acquiring the infection. But with those words, I can confidently tell you that this too shall pass, and hopefully things will continue to get better. Now, there are reasons to do our case. To be perfectly candid, it did cross our mind whether we should cancel today. Yet, it is precisely events like today which demonstrate the power of doing a live webcast as opposed to doing a meeting with the thousands of people. The American College of Cardiology, where I was supposed to head in a week's time, of course, has been cancelled. And what better way to bring a live case to your home in your comfort when you can review it, either watch it live or subsequent. So herein lies the power of our webcast, and hopefully this will continue uninterrupted. I also wanted to share a moment about attending the remarkable CRT meeting, and my congratulations to Ron Waxman and his group for putting up an excellent meeting. At the meeting also, once again, I came across so many of you who had excellent feedbacks regarding our webcast. I humbly sought so many of your suggestions, and I came back with numerous notes how to continue performing better, but thank you so much for your support. Now on to today's case. It's a chronic total occlusion, probably with the retrograde approach, but let me take you to the Cardiac Cath lab where Dr. Kinney and Dr. Sharma are ready and available today to teach you tips and tricks of doing a chronic total occlusion. Samin, good morning. Anu, good morning.
Yeah, good morning.
Good morning. As you said, actually one of my attending remarked yesterday also that we could have the highest viewership of today's episode because half of people are not working. The clinical diversion, so maybe they'll get more education, and we hope so because very interesting case which we felt few of the meetings when I've been, the people have been asking retrograde recanalization. We did one almost 3 years ago, which is there, but we felt that this will be the ideal case for retrograde recanalization because we had an angiogram few months ago and patient has totally occluded ostial LAD. Now, as far as the word of the retrograde, we always have taught in our hybrid algorithm of Mount Sinai that we do integrate, though fail, then only go retrograde. So I know a lot of people are quite gung-ho on the retrograde, but every trial of retrograde have shown more stent use, more procedural time, more non-QMI, and yes, it does increase the success of overall CTO procedure, but key is that retrograde should be reserved for selected group of patients. And this is kind of case which we sent to eBlast, that this was the ostial flush occlusion of the LAD, and you could not see any origin of the LAD and from the left main.
I mean, not only was the web blast there, but we also saw the videos, and exactly the ostial occlusion was visible.
Okay. Anu, now with that note, let's just quickly go through our presentation and we'll show what we have for today. These are our disclosures. Usually, this patient is a 52-year-old male, and he presented actually with acute hypercarbic respiratory failure and was intubated and has acute reduced heart failure, 32% EF, and troponin was 12. So that by definition, it was type 2 MI. And one of my discussion point today will be how to differentiate this type 1 and type 2 MI. Patient was stabilized on medical therapy, extubated, and then was catheterized. And we'll show you that. And then managed medically even after cath due to multiple medical and psychiatric issue. Later on, patient did well, followed in the clinic, and then came with the stress MPI, which showed significant ischemia in the anterior wall. EF now improved to 42%. Has been on good medical therapy as shown here, and the angiogram Anu is going to show now.
So this is where we took the first picture of the right. You can see it. So right, we had better retrograde collaterals to the LAD from the septals, but you still see then the conus filling the LAD.
What if you inject more in the left system than the right today? I know you start with the right.
Yeah, I know.
If you inject more with the left.
So this is where we are.
Yeah, no.
So you
want to go back to the same view and I'll inject the left first?
No, why left? You need the right.
No, from the left side so that you can see more your septal collaterals. Right? That was
I
the
don't think
question
so.
That you don't see the collaterals now.
Mm-hmm.
Samin, significant change in the angiographic appearance between this and the other one, and does it make you think about giving a shot with antigrade?
Well, I mean, you definitely see a very micro channel at present. I mean, again, by our teaching.
And the collaterals have become less prominent.
Yes.
Yeah.
So I would say.
No, I would go. Let's say just inject the right and see once.
So what we'll do? No, left you mean. So we can see collaterals.
Right.
Okay, only right. Good. So let's go to the same view.
Yes.
We need to go to different view, right?
No, this view.
Yeah.
Just inject the right.
Okay. So basically, whether we do the intervention CTO by, or I would call, let's say, subtotal C, by the injection, by technique, but maybe we'll just, Anu will show the steps of the retrograde. So just to show the steps of the retrograde, that's the key. So there's nothing wrong in that. What you do is, you want to wire the antigrade first, or what do you want to do?
No, I can say how we go to retrograde.
Yeah. So let's go to the retrograde approach. So I think that's the goal today, even if we don't need to, because you're right. Why to risk a patient for a technique which may cause harm, as long as we can just show the technical tips. Okay, starting with the catheter use and the wire.
So we have the Corsair, and also you have to make sure Corsair comes in a two length, 130, 35, and the other one is 150. So you need the long one, 150. So the color is different. This is dark blue. The other one is, like a light blue to green color. So this is a Corsair which we take, which is, is nice braided. So traversing through the septal is much easier if you use a Corsair, and you will go with the whatever your workhorse wire. We like to go with the regular fielder, and once you are at the septal, usually I think if you see here where the LED is occluded, the first to second septal that's coming off the PDA, you will start surfing the septal using a fielder FC wire because the tip is very floppy.
Now comment also, there is an epicardial collateral from the mid to distal RCA, like a RV branch, which goes to the apical LAD. Should that be selected, or do you still want to get a poke through the septal from the PDA?
No, always use the septals. We've never tried. We have done epicardial maybe once or twice when a patient who has had bypass surgeries, but otherwise try not to go to epicardial. That way you can even see the apical LAD that is filling from an RV branch. So they are very superficial, and risk of perforation and pericardial tamponade is very high with that. So just go through the intramyocardial septal. So I'll just show here, and then I think even if it goes through, let's see whether we can get through any septals easily.
So Samin, I was looking at some of my notes I have sometimes maintained in 2018 and before. The escalation strategy used to be fielder wire, miracle, and then moving to Confianza. Around 2019 and I think around this year also, I have noticed the technique to be changing to a fielder, a Gaia, and a Confianza. Is any of those your preferred strategy even today?
Yeah, I think that.
Yeah, for antigrade, yes.
Yeah.
So,
Excellent.
but retrograde, since the retrograde cap is softer, you can use these softer wires as.
No, but go with the regular fielder FC.
No, I'm going regular fielders to reach the septal. Once I reach the septal, change it to fielder FC. So same, goes easy,
Good.
right?
You need to go to another view. Where
Yeah, I know. I will just go to RAO view and see which septal probably will be closer to the LAD. What do you have, fielder FC?
So we are still going antigrade right now.
No, retrograde.
Yeah, no, I'm saying this injection-wise, RCA injection. Yeah. But have you
Some
attended-
anti, some RCA picture, so I know I am in the PDA.
No.
Not in the PDA,
Yeah.
right?
So we went into some other branch.
AV.
So
Okay,
first
now
thing
die.
first. Yeah, you pull back your.
Yes.
Anu, what is this is both 6 French based or?
Yes, both are 6 French.
And as anticoagulant,
We have we use Angiomax, but most people will use heparin.
But it will give a not full dose of Angiomax, right? Usually 2/3 first, and once you cross, then
Now
you
with the retrograde, you have to be careful with 2 guide and all that. Nothing wrong to have your ACT, just about 280, 290. Now here, what many people will do is give an injection into the septal right here when you're very close and see how the septal fanning is and then decide which septal to go. But I'll just try if the septal is connected. So you don't want to go too distal to the PDA. Stay closer.
You want to inject a little better, you'll tell me we'll
Okay,
inject.
inject now. Ready?
Yeah. Make sure we give some more medicine to the patient.
So if you see, actually, if you think the septal that's really connected is way distal.
yeah,
Yeah,
absolutely.
maybe too far for us. Let me
okay.
try.
Quite different from how the initial angiograms looked.
Right. And there's a gap of 5 months actually in the first angiogram and this.
Had you considered doing the procedure sooner?
No, because one of the big issue was the compliance of this patient. So we wanted to see the patient in the office, do the stress test and commitment from the patient in terms of the patient going to continue DAPT and so, and resolve many of the psychiatric issues. Yes.
Appropriate utilization criteria.
Yeah, absolutely.
Exactly the
Okay, show me
copybook
some dye.
right way of doing it.
The guide is too far out. But
See
this
now
will be okay.
this is the right septal,
Then start
and
with
let me see if we'll go here. If the septal to
Imaging
septal
has
connection is
improved.
very good,
Imaging
the
capture
wire
is
should
improved.
go by itself. You don't need.
And you advance the corsair at this moment.
Yeah.
Keep giving it more support and
Yeah. Also, they have shown that if your collateral is coming 90-degree angle, the chances of your retrograde failure are much higher because even the corsair will not make the turn and many times can cause perforation.
So ideally, you see that this is how you will find a septal, and if we were septal to septal connection was good, change to fielder FC, and we will just get into the LAD. Should
So why
be
don't
no.
you just try up to the ostium? Can you advance so that wire goes
I
further?
think it's not going. I
Then
don't
you
want to
get a
perforate.
fielder FC?
We can, but none of the septals are connected. Believe me, we would have had a septal by now. See,
so Samin, here is a very
you can give me a fielder FC, but
interesting feedback. I asked one of the fellows at the same CRT meeting where I mentioned about, and he said, yes, we would like to see more CTOs and retrograde.
Yeah.
So,
That's actually has been a theme by many people. I've had the same.
so this was totally unplanned as to the comment which was made by this particular fellow, but I think a very nice moment to recapitulate all the changes in your wire escalation strategy, show some of the new things, and
Right. And one actually other point, when I was in the India Live, of course, everybody is so thankful what we have been doing and trying to teach people. And more importantly, that have a ready-made slides on the PowerPoint, because otherwise you have to pay for the PowerPoint slides of the latest topic, which I work hard to make for our audience. There was that they said that maybe in the difficult guiding situations, just try to go through it. Only problem with us is that we use the marked guide, which nobody, at least I can tell you from India point of view, as you know, the Boston Scientific guide catheter, they have very small share. The majority are there with the Medtronic and the Cordis.
right.
Yeah, so they actually have less than 10%, but we
I
like
would take
them.
a picture here.
Yeah.
RCA picture.
Okay. We like the mark guide because of they very softer and do not cause the trauma. Now the other is the runaway guide of Boston Scientific. They're a little stiffer, but overall their market penetration is very little. So, but we have been very happy, and we do use like 5 French EBUs and other designs, but our majority interventions are done with the mark guide. So that's where, but the same, the VODA it's kind of EBU and XB, all are the modification
Take
of
this
the
out.
VODA variety.
And then you go to antigrade.
And
Okay.
VODA is the one which is a successful, in particularly the complex, the circumflex. I know that you wrote that paper many years ago in Jack.
1995.
Yeah. So we just started that time. Nobody knew. The Boston Scientific just came with this VODA guide, and we got into love with right away, just like the run-through wire. And since then, the VODA is our predominant guide catheter in our left-sided intervention.
So, Samin, without having gleaning or looking for the data, if you just think back, what percentage of cases do you think in the last 12 months would have been retrograde amongst the CTOs you've been doing?
Oh, our maybe let's say we do per month about 35 to 40 CTOs. As you see, this is which wire? Tell them what wire you use.
No, Fielder FC.
Fielder FC. Yeah, this is the Fielder FC. So retrograde of the let's say last year we did 500 CTOs. Retrograde will be in 5 cases. So extremely low in our group.
Less than 2%.
Yeah,
Okay.
exactly.
And the overall success is in the 90s?
Yes, yeah, overall success in the 90s, and we rely on the same guy with the one time, bring back second time, and so we do not go with the star technique and integrate re-entry,
Right.
because that actually, to me, it should be abandoned. There are a lot of data, and I've seen patients who comes back, they have pruned all the branches, they've done the RCA re-entry technique, and all the branches of the RCA have been gone. And because of that, I'm very careful that we don't use the integrate dissections.
Okay, I think we go for
So,
an.
Samin, there
You
is
showed
a
that wire advancement, yeah.
Yes.
question from Dr. Gul Zaman Khan.
Yes.
Was antigrade approach tried previously? The answer is no.
No, nothing was done.
Right.
This patient was left alone, yes. Yeah, but this is the way wire will go, and you can
Usually,
advance.
subtle to subtle is good. By now, it will reach the
Yeah.
LAD.
But try
Now
to
you see
advance
that.
a bit more, yeah.
Now somebody has told the guide is coming out.
No, it will go. No.
So very careful advancement of the Corsair there.
See that this subtle to subtle is probably torches there.
Please.
Okay.
Okay. Yeah. Or live mask. Okay. Get the mask. Mask
Who
on.
wants?
No cap. Yeah. Virus doesn't go to the hair.
This is the changing world.
Yeah. Yeah, you should get the mask also.
Who is saying?
All right. I don't know if somebody looks at the eye, that's okay.
Yeah.
Yeah.
My own personal attitude in these matters is better to comply rather than
Filter absent.
That's correct. Yeah. Get the mask also. Good. So now we go anti-hit. What do you need?
Let me see.
We'll refine cost. You have it?
Do we
Okay, while
use
you're
it?
getting your stuff together, let's just complete our case presentation.
Fine.
Go back to the slides. Yeah. So therefore, on February 3rd, patient had a one vessel CAD, flushed long, 100% occlusion of ostial LAD with excellent collateral from RCA. CTO score is 3, LVEF 48% and syntax score of 20. No PCI was done and managed medically. Patient compliant with meds, follow visit and has class 2 angina. Because of that had a
Give
stress
me
test and
miracle,
now
I
here
guess.
for CTO RCA PCI. And this patient with a one vessel disease because of intermediate to high risk finding on non-invasive testing and dual anti-ischemic therapy, anti-anginal therapy will be appropriate because of continued symptoms. So this is where we are now in this particular case. And Anu, tell us what's your strategy now?
I can see channel, so I'm going to use the same filter wire. Otherwise, next will be Miracle, and I know Samir was mentioning Gaia. For the reason I would try Miracle here is only we can make a better curve. And if you see, can you see the angiogram?
You play again?
Exactly
yeah,
where
this is
LAD
the
is
channel, yeah.
originating.
Right there.
yes, yes, we do.
Yeah, for that you need sharp curve, which we can only make it on the Miracle 6. So that's the reason I will
Or Gaia
likely.
2. No, Gaia 2 can make that curve also.
No. Gaia 2, if you make a special curve, it does not hold it. Yeah. Okay, so let me see now. Hold on. So I went back to Fielder fine cross.
And to make a less caudal.
Yeah, can't see much.
Anu, a question has come for you.
Mm-hmm.
Just reading the name, last name, some Dr. Joseph. Why do you like the Gaia wire?
No, this is a newer generation Gaia wire. I think if we had slides, as next time when we are doing CTO, you should show the slides of the CTO wires.
Yeah.
So its tip is already pre-curved, but the good thing about the Gaia wire also is the one-to-one curve is very good.
And they're based on
And
that.
they deflect. They're supposed to deflect from the CTO wall.
Try to avoid not going
Yes,
into the
into
subintimal
subintimal
space.
space.
So that rope technology, that the wire is interwoven, and to me, actually, once it goes to the distal part, it just jumps forward with a great success. So Gaia 2 and Gaia 3, we don't carry Gaia 1, but Gaia 2 with increasing strength of the Gaia 3 are our escalation strategy before going to Confianza now. So Gaia 2 and Gaia 3, actually at present for the CTO wire, they hold the maximum share all over the world in terms of CTO recanalization wire of the Gaia 2 and Gaia 3. But you need to get a little used to it. In the beginning, it may not work. You may feel that, it's a wasted effort, but I can tell you, try 10 cases. You'll get in love with this wire.
One-to-one torque is very good.
Yeah.
In that wire. Can you see this? Okay.
Good. So now you have brought the fine cross up to the tip into the proximal part, and now you may not be able to go through this fielder or,
Get us the Gaia now, Gaia 3.
Yeah, right here. This is the Gaia? No, this is the Miracle.
Oh.
You want Miracle or Gaia 2? I would have gone with the Gaia 2.
So, I mean, two more questions.
Gaia 3.
Almost simultaneous. Both wondering whether this is they are finding it and commenting on being a unique strategy rather than starting with antegrade to go retrograde and abandon then quickly and go back to antegrade.
No. But this case, actually, let's put this way: if we would not have advertised as a retrograde, we would not even try the retrograde.
I think
we just wanted to show the steps. That's it.
Steps, exactly.
Yes, that's only. Yes.
No.
And I have a
100%
feeling that
our teaching point is antegrade first.
Yeah. This
The
case
two-
will try first and second time antegrade, fail, then only you go to retrograde. Yes.
I'm almost certain what happens is, I mean, this is, I have not only noticed it, but people provide a feedback. Sometimes people have joined in the middle and they may have missed out that earlier comment.
Exactly.
But your thought process and your question is welcomed and exactly right in thinking, but the approach as clarified, always prefer antegrade and
Can you give some?
retrograde a far smaller minority of the cases.
Go epicranial so we can see. All right.
The
so
body
this-
habitus is such you can't see anything. Okay, now die. Somewhere else. Are you injecting wrong RCA?
No, but you need to go. Antegrade you are able to see. You need to go just.
No.
Okay.
Maybe in the diag. Yeah.
Now it comes with a pre-shaped curve of 0.5 millimeter, but then you have to make a second curve in case you need to have an angle in advancing like this particular case. Okay. Want to go a little more cranial. Let's get a little better view that where your LED eye is. Yeah.
It's very high. Come down.
Good.
Okay, now
I'm going to
die.
inject now. Sine. You may need a second curve in that Gaia.
Seems to be and your support catheter here is the fine cross.
Yes, bind cross. Yeah.
Okay. You think we can see something?
Okay. Good. Move that BP cuff.
RCA, right?
Yeah, no, 1 second, 1 second. Let them remove. Fluoro? Did they remove? No.
I think, yeah. Out?
Nope.
So, I mean, there's a question by a Dr. Kumar. He's asking, we do not have Corsair
Confianza.
in our laboratory. Is there an alternative we could use?
Turnpike, LP.
Turnpike. No, they still have. Why?
Okay, his maybe it's EKG.
Turnpike, there's
EKG.
another one turnpike, or otherwise you still can use the fine cross.
Right.
No,
How
for
you can-
retrograde. You
Yeah, no,
cannot.
I know, but question is, what else can you do? You can
Micro
people-
14 is another catheter that you can use
Yeah, before
retrograde.
this came, the
Turnpike.
Corsair came, we used, yeah, good. We used to use the micro, the over the wire even people used to use.
Ready?
Then, yeah. Yeah, so far, until there is good.
Looking good.
Then,
looking
yeah,
good.
it's a, no, then it has gone same, not for into the.
Yeah.
I
So this was
actually
made special. Yeah.
like the previous view you had. You
Yeah.
like this one?
Epicranial. No,
Yeah, I
I
thought,
think we'll not know where to make a
right,
lower turn, and you
exactly.
need to make additional tip curve on this Gaia.
Or make
Yeah.
you'll not make it, or go to Confianza.
That's towards the diagonal.
Here you will not know. You need to go to other view or Myocardial.
Okay, now die.
Okay, there you go.
No, but LED versus what? Let's see.
Diagonal, you think?
Yeah.
Yeah, diagonal.
Here you need to do
But headed in the
at
right.
that level here. Yeah. No, definitely.
Little more curve there.
Yeah, but Corsair, I mean, the fine cross is not going in, so.
No, it will go once the body of the wire will be there. Same diagonal.
Would
And you see the
even-
corkscrew
would you-
movement. Yeah, yeah. It will went in. Yeah.
Okay, you
Right.
can go with the, I think, run.
Would you even at some, maybe at this stage,
Guys,
even
what run
consider
through
a
have you given me?
parallel wire?
300.
No, this one is good. No, I think this one, parallel wire is a one, clearly good technique. But in this particular case, there is
It's
no
looking
reason.
very promising.
It's
looking
promising. It
very
just
promising.
need to deflect down because you
That
see.
is why, remember I said Miracle 6 would have been because you can make a better curve. I can tell you, Gaia, when you make a second curve, getting it into the microcatheter is much harder. And I think this is another thing we have seen many times. It does go subintimal, so you have to be very cautious. Okay, here, 1-to-1 torque is very good. Here, take this wire out.
Are you okay in this view or you want to go in different view?
No, I'm okay. So okay. I know exactly where the LED is. That is still. Now some dye. I may have to pull back. Unless we are not in the LED. Subintimal, you think?
I think it has to be a different view. We know that we have gone into the diagonal. Your fine cross has gone quite a bit. Now you need to make a vertical turn onto the wire. Whether run through, whisper, diagonal again.
Okay.
Looks in a septal there, maybe.
No, it's still the diagonal.
Still the diagonal. Okay.
Diagonal,
I have a confiance already. You have it, right? Don't open yet. Don't open yet.
Just 1 second. A little bit more. Good. Ready? I'm going to give an injection. Retrograde, you want to cine or just fluoro? Cine. Looks like there is a second occlusion.
No, there's no second occlusion. We have not made the turn into the
LED.
So you need get back your Miracle or your or Gayatri.
Here,
just
that Gayatri.
There, Confianza. Or
make a little curve on the Gayatri. You'll go in.
No.
Samin, as I was thinking about what you have mentioned about your CTO techniques, you clearly, both of you are different in your total lack of belief in any re-entry techniques.
Right, yes. And also because we know that technique all have been associated with higher, the original paper, I know it has gotten quite a bit, the initial was a lot of enthusiasm, then subsequent publications, not only higher procedural complication, more CKMB release, but higher reocclusion and higher restenosis from our lab, the CTO registry. So because of that, we actually, we did try this device in the beginning. You want to see it?
It is not.
But
I think
we never, kind of go to,
Making a lot of progress.
Done.
And
Done.
Subintimal still. I'm telling you, it's not
Confianza?
No, this is our same Miracle 3.
No. I mean Gayatri.
Sorry, Gayatri. Sorry, Gayatri. Yeah, Gayatri. No, you're there now. You will make it. But now, same. It's since we made a little extra curve, it will go against you even after cross. So we have to be a little careful as being done.
I think we are subintimal. Give me Confianza.
Okay. No, but if you go a little further, we'll go. You want to take a stene?
Give me Confianza.
I mean, another question for you. Most of your CTOs are tried through the femoral approach.
Yeah, you actually, what we have is with the contralateral injection, if there is no issue about the ipsilateral bridge collaterals, so we will go with the left radial and right femoral. Rare cases we have bilateral radial, which people do. Same thing like which was published in the registry, that most common favorite approach for CTO nowadays increasingly is the left radial and right femoral. Because point is, you can't have a right radial and right femoral, then you are far away from the table. And having a both femoral is also good approach, but that has increased slightly higher vascular complications.
So
both radials is a little more complex, yeah.
Left, let's say the preferred left radial, right femoral.
Yeah.
Which is the one where you are using as the primary guiding
right femoral, right. Because yeah, exactly. So you have to change the guide, you need a little extra guide support, all those things can be done.
Absolutely.
Yeah. Don't see? Looks better.
No. I can tell you that Gaia took a subintimal. Should have been.
So this is the second CTO. You see that?
Right.
Yeah.
Well, either or a very long segment, hard to make out, but
I think we're far away.
Is the tip feeling free?
Yeah, but could be somewhere else.
Samin, sounds appropriate to even ask you, because I'm sure, although unrelated to our present case, this can offer guidance to a lot of people watching. You may have just crossed there, and that cannot be.
But see how I did it?
You go.
You see how I did? I went all the way proximal
Back.
and re-entered. Yeah.
Run through.
So Gaia had taken us all the way subintimal. So we had to go back to the proximal cap and re-enter with the confianza. Proximal cap.
Excellent technique. I
2020.
I'm just hoping that people would have noticed the last 2 minutes of the case, and that I believe is the entire teaching where this strategic and correct decision needed to be made, that look, you are headed into a subintimal course, and how do you navigate through that? And excellent technique, Anu, and super job. Samin, here is the a very tricky issue, but I think it would be on the minds of so many people, and we might as well address it. How are you doing at Mount Sinai regarding elective cases in the presence of the crisis?
Crying.
No, what is very important is we are calling the patients who definitely have symptoms. You cannot ask them not to come and have procedures. So if they're having symptoms and patient is willing to come, you know, everybody knows about it, and patient is willing to come and they have symptoms, especially now they're calling us because the stress test is strongly positive, large ischemia, those kind of patients, we are doing them.
Yeah.
And
the key is that yes, we are following the concept that do only
not true elective
cases, but we have categorized the third category. Urgent acute coronary syndrome is separate.
Yeah,
elective is stable patient separate, but we are saying elective sick. That means that patient has ongoing symptoms. We are postponing, because what happened is we don't know the end game. So what we thinking that if patient condition we think is not going to deteriorate in 1 month, so that is okay to postpone that patient. And we tried yesterday, just give you an example, like 50 patients. Of the 50,
do you
30...
want to take a cine and confirm?
Yeah,
so that,
okay. Of the 50, 30 confirmed to reschedule, but other 20 said no. We are symptomatic, we are coming.
Right.
I just want to, but the key is following the principle by the governor, by the mayor, and so, yeah.
And
no, so you see that there's significant...
CDC, I think, is... yes, Anu?
No, mid to distal, there is significant disease, even when we did original picture. So we just have to be very careful. So remember, we are a believer of you enter the proximal cap, exit the distal cap, whatever the length of the CTO is, that's what you need to stent.
So
I'm a strong believer of that. Yeah.
A long balloon to start with?
No, we have a 2.5.
No, this is 2.0 right now.
2.0?
It's a 2.020 compliant, and then we have to put a wire into should put a wire in the diagonal.
Not yet.
Okay.
Yeah.
Nice.
So that will go away otherwise. Okay.
Okay. So the length of the stent has to be the length of the CTO. But here, this for disease in the mid to distal LAD, we will need another stent there.
Yeah. And I'm hoping that could be our myocardial bridge. We don't know. But I'm saying we need to integrate flow to really see it. Many of those cases when we open them and it turns out to be a myocardial bridge. Here you need 2.5 or 3.030. I think we can take a 3.030 balloon. Let's open. Here, no proximity.
Go up here. There's I can.
You have filter wire ready in case.
There's calcium also. I don't know if you can appreciate it on the fluoroscopy. Samir?
Integrated
yes,
now.
yes, I did notice that.
So integrated.
Not, I would call it probably moderate, no?
Yes.
Why we did not establish flow?
Because we did not. The one distal more important, we have to dilate it well. There was only a 2.0 balloon.
Yeah.
Once we go with the 3.0,
yeah.
we'll be fine.
2.5 or 2.75?
No, he gave a 3.030.
3.0 he gave.
3.030, okay, that's good.
Samin, what is your, have you established a cutoff of either the fluoro time or the amount of dye for the CTOs?
Fluoro.
Flow.
And how much?
Fluoro above 10 milligray, because now that is reportable to the state above. So you got to be cautious. So now you see it, our thing is already saying we are 2.2 milligrays in this on this machine. That is also, we are not high fluoro, we are medium fluoro, and body habitus of this patient is not favoring us. So we already have crossed 2.
And then
So
see the fluoro time of 100.
Yeah.
As soon as you go to the 3 digit is bad.
Yeah.
What
So fluoro
made
time
you-
right now 28.
What made you not, what made you de-emphasize the amount of dye?
This is a state reportable event now. JACO wants this reported.
No, I understand that, but
yeah.
previously we used to also focus
Yeah,
a
yeah,
lot
dye is
on the
part
amount-
of it.
Right.
Dye, but somehow dye is lower,
No
or
cutoff,
everybody's
no
doing, yeah,
cutoff.
there's no cutoff.
Yeah.
You know, we want
But-
to keep it lower, but this fluoro is not in our hands.
Right.
Right. And but
Dye
yeah, you're
can
right.
be, yes.
Many papers have shown that the contrast volume more than 5 cc per kilogram body weight. So if you have 60 kilo, you give more than 300, you are in more trouble.
Don't you have
So
to
that
come
is
up
a
to the
cutoff for
ostium?
many of them.
Maybe we never dilated the ostium, that's why we never saw the antigrade flow. No,
So that also has
Yeah,
happened.
because it almost starts in the ostium.
Go up.
You're right.
Yes, we never dilated the ostium. Okay, now we'll see the flow.
Now
This
it's
is
still
down,
a little more
down.
back, right?
Yeah,
It,
cutting.
wait 1 second, let it deflate.
Okay. So I will come into the left main.
Yeah.
We may have to do a cutting balloon there. Almost maybe a 3.5, right? Okay, now we opened. See there? Now you see antigrade flow.
Do a Fogarty and then we'll take a picture.
Before we dilate the distal LAD lesion, let's take a,
Right. Yeah.
right? Not going down.
Then
There
dilate
we
here.
go.
Yeah.
Yeah,
Here we have to dilate.
yes. We probably need 2 stents then, just here, down.
But 1 second. You have the little nitro to give it later.
Now take a picture now. Go to the
want to do
RAOSS so we can see the ostium. You think so? You want to go low fluoro? Can't see anything. Now we went to low fluoro once we crossed.
Good. Ready?
Go. Yeah, now you
Excellent
see it.
flow now. Yeah.
Go to quarter or what?
Exactly.
Maybe one
right,
of the
I think,
live case we need to show what are the tips, tricks to avoid excess radiation.
Right.
You can see in this view.
The angle, the views, what you can do. Right? Yeah.
Well, the biggest change I can tell you I have made in my own practice is it's been years I used LAO cranial. That's gone.
Yeah,
Even
yes.
the LAO
Yeah.
caudal
No,
is
no,
gone.
see
I've
this one,
converted
you-
it to a
You see me using this collimators.
We
Collimators are
don't
very
do the
good.
aleocranial at all.
Absolutely, because I think the more angulated a view and nothing like the aleocranial and even the aleocaudal is gone, it's all
What you want to
apicaudal.
do?
Now you tell us the
3-5.
strategy and we go for my injection.
No, no, no. What I would say is we would put a 3-5-33 there, or you want to
Proximal.
see here?
No, I think put
distal
a
there's
stand
disease.
first proximally and then decide what to do further down.
Further down there is disease.
Yeah, but that you will decide after
Later?
putting the stent proximally.
Okay, get us a 3-5-38.
Okay. All right. While we are trying to get, let's go to our slide presentation. We go a little bit more. So what I'm going to talk about 2 points, particularly prognosis of type 1, MI versus type 2. And second is meta-analysis of randomized clinical trial for unprotected left main PCI versus cabbage, which was just published. So basically, prognosis of type 1 or 2. So there is a fourth universal definition of MI. I'm actually one of the reviewers for there. My name is on the second page. In this, basically, what we follow of various kinds of MI from 1 to 5. And I'll show you what are those. And these are the multiple definitions. The latest one, which everybody used, is the fourth universal definition of myocardial infarction. And of course, we know that patients who present with a myocardial injury or have any time troponin elevation to a full myocardial infarction is a interplay of not only just the disease of the coronary, but various other factors, particularly those who cause the mismatch of the supply and demand, as shown in this particular diagram. So key is, we all know that besides the atherosclerotic plaque disruption with thrombosis, which is our acute myocardial ischemia, there are other regions, a lot of them which are shown here are the causes of myocardial infarction with the troponin elevation.
Good, right?
Like coronary artery spasm,
Okay.
microvascular dysfunction, coronary embolism, dissection, sustained Brady tachyarrhythmia, hypotension, respiratory failure, severe anemia. This particular case was classical example. Increased myocardial oxygen demand by sustained tachycardia, severe hypertension with or without LVH. So this case actually had this infarction, although has a CAD. Now then, there are cases where you see the troponin just elevated, no rise, rise and fall. The myocardial infarction is defined as rise and fall of troponin. What if the troponin is acutely or chronically elevated without any fluctuation? And that happens in patients with heart failure, cardiomyopathy, myocarditis, and many of those shown in this particular slide with a sepsis, infectious disease, and so. So basically, this is what it is. Rise and fall of the troponin over the 99th percentile, and that makes the type 1 or type 2, and we'll come back to what they are, or sustained acute or chronic myocardial injury, which persists for a long time. So clearly the short term rise and fall is representing the acute MI, and other is the myocardial injury. So now come back to the what are these MIs. The classical MI which we teach is the myocardial infarction type 1, which is caused by atherothrombotic CAD, and there is a plaque disruption, could have thrombus and no thrombus, but disruption which is causing the problem, occlusion of the vessel and creating the myocardial infarction. We know various gradation, unstable angina, non-STEMI, STEMI, based on the thrombus and obstruction of the lumen. And this basically has a classical acute ECG changes, symptoms, and so loss of myocardium and so. More important, which I want to focus today, is the myocardial infarction type 2. That is, many of these patients do have coronary artery disease, but there is no ischemic, there is no plaque rupture. They do have EKG changes, but it is the non-plaque related event causing the myocardial infarction, and that is because of supply and demand mismatch. Very simple. So basically, myocardial infarction type 2 is the supply and demand mismatch. Type 1 is a plaque rupture with or without thrombosis causing the obstruction. Both of them give rise to myocardial necrosis. But this is where we are. Basically, also have same symptoms of acute MI, EKG changes, pathologic Q wave, and imaging evidence of new loss of viable myocardium. But there is no thrombotic event in this case. So this group is actually more diverse compared to type 1 MI, which is our atherosclerotic MI. Type 2 is basically for the secondary to another illness, And key is that, of course, main region leading to clinical presentation like chest pain and so, and oxygen supply and demand imbalance of various conditions which have been highlighted in this slide. And this, how do basically work? That one, your troponin rise and fall is the MI, and with or without ischemia, acute myocardial injury, and if you have atherosclerotic thrombosis type 1, type 2 oxygen supply demand, and acute or chronic myocardial injury, elevated troponin representing the myocardial injury. So 3 conditions: myocardial injury, elevated troponin without rise and fall of troponin with thrombosis is type 1, rise and fall of troponin with oxygen supply demand without without thrombotic episode is your type 2 MI. So therefore, and now then there is a type 3 MI. And type 3 MI is that patient has the cardiac symptoms but died before you could do an enzyme. So if you don't have enzymes, but there were every way you felt that this patient has a coronary event. So that is the type 3 MI. Then people ask, what is the type 4 MI? Type 4 has A, B, and C. A is our post PCI, and that's where same patient EKG changes, new pathological T waves and Q waves and loss of myocardium, rise and fall exactly, and there are various criteria, whether it should be 5 times, 10 times, 35 times, and so. So type 4 AMI is post PCI. Then we have type 4B and 4C. 4B is stent thrombosis, and 4C is ISR or restenosis of the infarct area. Then we have type 5 MI, which is called post-cabbage. So these are again rise and fall. These are from 1, 2, 3, 4A, 4B, 4C, and type 5. So just wanted to go through this overall definitions of various MIs. So now,
Samin, just quickly to recap the importance of it, because this is changing so fast and evolving. Is the real basis here is the dynamic troponin levels, no?
That is correct, absolutely. And dynamic troponin level region is that, and then to manage these patients, you know what happened? They come to the cath lab, you see 60-70% lesion, and you say, well, this patient will do okay. There's not to worry about her type 2 MI, and that's where the whole question has evolved in last 5 years. The type 2 MI, that what is the outcome of this type 2 MI compared to your classical non-STEMI and STEMI? And this is eye-opener. Look at this here.
Also, I think it offers clarity in the post-PCI and post-cabbage subgroups.
Absolutely. Yes, type 4A and type 5. Now, look at this one now. Prognosis of the patients who are index event in terms of mortality. Type 1 MI, your mortality at 5 years was 40%. Type 2, that mortality goes down to 60%. And myocardial injury, mortality goes down to 70%, 75% at 5 years. So what does it mean?
You mean the survival actually?
Well, actually the survival from any cause of the death.
Right.
Yes.
Got it.
Yeah. So key is that clearly the type 1 has a is still benign compared to other 2. So that basically is the type 2 has a higher mortality, type myocardial injury even have further higher mortality, and this actually has shown that cardiovascular, non-cardiovascular death, that particularly why type 1 MI, most of the deaths are cardiovascular, but non-cardiovascular deaths predominant in the type 2 MI and myocardial injury because they have more comorbid conditions. And so, and also if you have a CAD versus non-CAD, type 2 MI, if you have a CAD, your event rate or for subsequent death rate is much higher compared to if you do not have a CAD. So type 2 MI could have CAD and non-CAD, but CAD impart additional bad prognosis. So they concluded that despite an excess in non-cardiovascular death, this is data from British with type 2 MI or injury have a similar crude rate of major adverse cardiovascular event as those with type 1. Identifying underlying coronary heart disease in this vulnerable population may help target therapies that could modify future risk. The latest paper came from 2 centers, Yale and Brigham. The cardiovascular mortality after type 1 and type 2 MI, they have the Young MI project in young adults, less than 50 years of age. Now you say, well, maybe the earlier paper showed the old people, multiple disease, maybe they have more trouble. What about the younger people? That is the less than 50 years of age, and here the overall incidence in this 3,800 patients. Type 1 was 55, type 2 was 32, myocardial injury was 13, and you can see the patients with the type 2 MI in younger, more likely women, cardiovascular risk factors were low. Non-cardiovascular comorbidities are high. And of course, the medications patient went home are low. So basically what does it mean? That type 2 MI occurs in the less risk factor but more comorbid conditions as is not treated properly at this time. And what is it cause? Look at the in-hospital mortality. Injury, 20% mortality, type 2, 13%, type 1 MI, 2%. And corresponding long-term mortality at follow-up of 10 years. So just to show that type 2 and type myocardial injury, whether it is because of the comorbid conditions or we don't know how to manage them properly, have a higher in-hospital and follow-up mortality compared to type 1 MI, which we know how to treat them. Take them to the cath lab, do the good intervention, and so on and so forth. This is same cardiovascular and non-cardiovascular cause, which I showed in the long-term all-cause cardiovascular mortality. Type 1 MI was the reference, and of course injury and type 2 MI has a higher. Now, what are the etiology of this type 2 MI and myocardial injury shown here? Etiology of type 2 MI, majority of them are sepsis, arrhythmia, hypoxia, spasm, heart failure. The little difference between two, but kind of okay. Similar, a lot of overlapping causes of type 2 MI and myocardial injury. More important, the what type of the myocardial injury or clinical condition has associated mortality, all-cause death or cardiovascular death. As you can see here, if you arrest sepsis, anemia, majority of them will be the all-cause death. They won't have a cardiovascular death. Cardiovascular death happens, patients who are hypotension, hypertension, heart failure. So each condition causing type 2 MI or myocardial injury has a differential associated mortality. So basically what they authors concluded, the young patients who experience a type 2 MI have higher long-term all-cause and cardiovascular mortality than those who experience type 1 MI, with nearly one half of the patient with myocardial injury and more than 1/3 of the patient with type 2 MI dying within 10 years. So this is an eye-opener. I can tell you, before I learned this subject in last few years, did not know this. Unbelievable. These findings emphasize the need to provide more aggressive secondary prevention for patients who experience type 2 MI and myocardial injury, because we don't think about it. So clearly was the type 2 myocardial infarction. There was a paper written few years ago that how do you manage, very complex, but just to go through various points in terms of diagnosis and treatment of these patients appropriately. Don't write it off. That's a type 2 MI. You have to go further. Angiogram, whether patient need intervention, patient anemia correction, trachybrady treatment, treatment of heart failure, all are part of it. And this actually, the editorial was the gloomy long-term prognosis of patient with type 2 MI or myocardial injury. There is an ongoing trial, randomized trial going on called Act 2, which is the appropriateness of coronary investigation in myocardial injury and type 2 MI, which is basically the patients going a routine therapy or they're getting the cardiac cath, and there is another trial which you look doing the imaging testing and then basically approach more aggressively these patients rather than wait and watch, which have been done in the past for this management. So therefore, we actually at Sinai took this type 2 MI project task force. Usman Bauer is the lead person for that, and we actually have gone through the same purposes type 2 MI initiative. And what we have done over last 1 year is a significant, clearly the diagnosis, appropriate diagnosis and treatment. Patients who have type 2 MI, they get a cardiology consultation, what to do with the patient, whether majority of these patients occur in the setting of outside the ICU, medicine floor, ADS and so. So clearly this initiative of type 2 MI, which has been taken by us as well as in the countrywide, and will get some guidance by some randomized trial, will, in my guess will be, or hope, that in few years we'll have a better outcome of the type 2 MIs. Okay, now it looks like the Anu is done here. Tell us what you did.
Anu, before you ask, tell us what you did, there is a very important question. Somebody asked that, were you, based on how it looked after you crossed the wire, did you have a crossover technique as a preferred technique in mind?
What crossover technique?
I think he's referring to crossing across the circumflex.
Oh, yeah, no.
No.
No, because
Okay.
till the ostium, so
Yeah,
you
yes.
can bring the, it's a 90-degree angle, you'll bring
And
a
there
stent
is-
up to the ostium, yeah.
Right, and there is no, right, you were not planning to place across the circoregion. Got it?
No, no, just
All
ostium
right,
of the LAD. We
yes,
put
yes.
two long stents, a lot of vasodilators, and this is where we are. The distal, we just did a balloon. I didn't want to put a third stent. This is how it looks. The diags are all patent, septals are all good.
And what was the
I think
size of the stents?
no, let
3.5 proximally, and we did a 3.0 in the
which
you know,
stent?
mid to distal.
What is that?
Zymes.
Excellent.
the giants. No, just to
excellent.
38,
coming back to
230.
that point, Samir, that's a very important question nowadays. That is, in the past, when we used to think that, you know what, let's avoid the left main because there's no disease, and we used to just try to say at the ostium, and most of the time miss the ostium, patient comes back. What threshold has changed, that if there is a question that you cannot cover the ostium with the, because it's not a 90-degree angle, then you should definitely cross over, bring it to the distal part of left main, and plus minus, of course, you do enlarge the stent in the left main, which we call pot or so, but enlarge to the left main side because your stent has to be size of the LAD, and then if necessary, you can do do a kissing balloon inflation, open the circ. But
So-
majority of the time, you can leave it alone. Yes.
In these particular cases, would you image with IVUS before making that decision?
IVUS of the LAD?
No, what Samin mentioned that, look, there is a possibility in some cases, there is a doubt that appropriate coverage of the ostium of the LAD may not be done, in which case, why not image first, give yourself a better idea that, look, I will stent across.
I would say that a lot of people may use the IVUS, but I'll show the data actually. That's a part of the high volume operator for this situation can make a decision without IVUS
Absolutely.
also.
Got
Yeah.
it.
So I mean, if distal left main is involved, if the distal left
Right.
main you have some disease, like here,
Angiographic,
if
yeah.
you can see here, look at that,
Nothing.
distal left
But
main does
Anu,
no
won't-
disease.
Won't you also say that by angiography you would be underappreciating the distal
Not-
left main disease?
Yes, but in this case, angiographically, the left main looks clear,
Looks very
clean.
good. Yeah.
So this is where we place a stent. If you see here, covering the ostium,
And you
And
did
inflation.
ostium
not
of the LAD. Yeah.
you did
correct.
not use any cutting balloon there.
No, just the balloon. We did it, 2 long stents and a lot of vasodilators, and this is where the final angio is.
Outstanding result, excellent techniques. Samin, a quick review of your second point
Your
before
second
we
point
No,
come
I
back
just
the
want to
case.
make a point of
Yes,
here
Anu?
crossing where we did the crossing. If you see all the side branch, which is the diagonals as well as the septals are patent because of the technique that was used, that you enter at the proximal cap and exit at the distal cap. If the same thing we had done, so when I knew that the guy at 3 was subintimal, you re-enter with a different wire in the proximal cap, so not re-enter distally, because you don't know now where you're going to re-enter distally, in which case you'll have a lot of subintimal track and you can lose your side branches. So the right way to do is the technique that we showed today. So you're entering at the proximal cap, exit at the distal cap, and cover the entire CTO, so your branches are still patent.
Superb technique and excellent explanation, Anu.
Okay, we can go to the slides now. Now then, second question was the left main, the meta-analysis which just came, and why this is because of this conclusion of the XL5 here, which is really, I know we have spoken quite a bit, but this kind of will be the end to this controversy, because the conclusion was the patient with the left main CAD, lower intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to rate of the composite outcome of death, stroke, or myocardial infarction. But why, as you see, that underlined up earlier in the results, that death from any cause occurred higher in the PCI group compared to CABG group with a 3.1% difference point. So this has really led to the numerous trials, numerous data, publications, and so, the whole issue comes down to that we learned that in first year, PCI is better than CABG. Second year, they're equal, or I would say first month to 12 months, and then after 12 months, clearly the CABG has superiority, and largely because of MI. The question is it because of mortality? Now we know that 3.1% absolute difference in mortality in favor of CABG in the Excel trial. What about the other trials? So this is the in European Heart Journal, as you know, it's the highest impact cardiology journal, with a mortality after DES versus CABG for left main disease. Meta-analysis, they actually used the 5 randomized trials, which have various follow-up of the 5 to 10 years or 1 year. The Budrot is the trial from Germany, comparing cipher stent versus CABG, and basically showed that risk of death at latest follow-up is absolutely unity. 1.03, no difference in CABG or PCI. And then if you take a cardiac death is also same. So basically to show that combining the multiple trials, there is no increase in mortality after left main PCI over CABG. So very important message, which is what kind of percolating, not answered by Excel because it was a single trial, but just combining all of them had basically this message. Second, also kind of misnomer, we always felt that DES will have a lower stroke rate, and turns out to be, if you combine all the 5 trials, the stroke rate was not significant. Odd ratio of 0.74 with the 0.36, 1.50. So clearly no difference in stroke at follow-up, and myocardial infarction may have a little bit advantage, but still non-significant because the odd ratio 1.22 with a 0.96 and 1.56. So you cross the unity. So no significant difference of MI in CABG versus PCI. And the only thing is, all trials have shown that revascularization, TVR, is significantly higher in the PCI. So CABG is the winner in this group. So therefore, the conclusion was that totality of the randomized clinical trial evidence demonstrated similar long-term mortality after PCI with DES compared with the CABG in patient with the left main CAD. Nor were there significant differences in cardiac death, stroke or MI between PCI and CABG. Unplanned revascularization procedures were less common after CABG compared with PCI. These findings may inform clinical decision making between cardiologist, surgeon, and patient with left main CAD. So this actually is a very important point when the investigators, when the group, the reviewers will consider that where do we put left main PCI appropriateness in the upcoming guidelines. So there is a second point also has come, that is the impact of operator experience and volume on outcome after left main PCI. So turns out to be when you have experience with a less experienced operator, they define more than 25 cases to be done per year, 26, that patients who are experienced take more complex cases, more bifurcation, more the two-stent approach, and basically found that high volume operator, which you call experience versus low volume operator, more left mains are done. This is from Japan. The from China, that high volume operators are much higher, do the more intervention of the left main. But look at, despite complexity, death, cardiac death, MI, TVR is significantly, the combined as well as the stent thrombosis, all numerically or significantly lower with the high volume operator compared to low volume operator at 30 days and 3 years, as you can see here. Clearly, so you say, well, maybe we should go to the more experienced operator for the left main intervention, makes it a point. And this is the same way, the low volume versus high volume or intermediate volume, and that basically cutoff is somewhere around 25 to 26, where your mortality goes down, so this the predictors of death in this paper with the 3 years with the experienced operator having an odd ratio of 0.49. Now also showed that whether individual points like I was used or not used, high volume operator versus low volume, so it doesn't matter. So I was used did not matter. That was the question here. Non-bifurcation, bifurcation, and 2 stents. Clearly with the 2 stent, you'll say that, yeah, a high volume operator may be better compared to the low volume, but definitely with the 1 stent strategy, all are equal. Same thing with the non-bifurcation and so. But so IVUS did not make any difference. So therefore, impact of operator experience, patient underwent left main PCI by high volume and experienced operators had better short and long-term prognosis. So operator experience is an important factor in complex interventions such as left main PCI. We actually have another paper just published, actually abstract so far. Paper has not come out yet. And this is from the BCI, our British Cardiovascular Society National Database of 6,700 unprotected left main. And they divided the patient into, or operators, with the various quartile. So Q1, they're doing 2 left main PCI per year. Q2 were 5, Q3 11, and Q4 26. And they found higher volume operator taking care of more complex cases have a better outcome, lower in-hospital MACE, and better 12-month survival. So seems to be the volume does matter. So therefore, clearly, that you can make it a center of excellence for left main for the complex left main intervention at least. So coming back to our two take-home message, the type 2 MI mainly caused by supply-demand mismatch of myocardium is frequent occurrence in many medical conditions, and majority, more than 60% have obstructive CAD, but without a thrombotic process. Both type 2 MI and myocardial injury, no clear ischemic event, that is a myocardial injury, are associated with higher in-hospital and long-term mortality. Hence, appropriate diagnosis and subsequent management is essential to improve prognosis of type 2 MI and myocardial injury. Second, recent publication of meta-analysis of 5 randomized clinical trial of unprotected left main revascularization with 1 to 5 years of follow-up has shown similar mortality after PCI versus CABG. Also, MACE, MI, stroke were similar except higher TVR in the PCI group. So there has been also a clear relationship for unprotected left main PCI volume and outcome, particularly mortality. Hence, complex unprotected left main PCI should preferentially be done by the high volume operators like those do 26 per year. As you know, myself and Anu do about 200 of the left main interventions per year. So coming back to our 3 questions, following are the conditions associated with type 2 MI except sustained tachycardia, 70% obstructive CAD, coronary spasm, plaque rupture without thrombus, and severe anemia. So answer is clearly you could have plaque rupture or no thrombus, still remain. That's a type 1 MI. So wrong is, correct answer is D. So clearly that is not a type 2 MI. Second, recent registry data regarding type 2 MI in young adults are correct except mortality is higher versus type 1 MI. Patients have fewer cardiovascular risk factors versus type 1 MI. Patients have higher cardiovascular risk factors versus type 1 MI. Patients have more non-cardiovascular morbidity versus type 1. And patients are less likely to be prescribed cardiac medicines at discharge versus type 1. Clearly that they have a fewer cardiovascular risk factor, not the higher cardiovascular risk factor compared to type 1. Lastly, recent meta-analysis of randomized clinical trial comparing DES PCI versus CABG showed the following except similar all-cause mortality between PCI versus CABG, higher cardiac mortality with PCI versus CABG, no difference in stroke with PCI versus CABG, no difference in MI after PCI versus CABG, higher TVR with PCI versus CABG. Clearly, wrong answer is there is no higher cardiac mortality with PCI versus CABG. With that note, we end our today's webcast and discussion.
Samin, I could fill up an entire session with the comments and questions, but exactly right, this is a moment to halt here. One relevant, I think, concluding remark I would make is that finally, I hope the controversy has been put aside regarding what happened after Excel. And as you mentioned, I think this provides very important guidelines for the heart team, which was left in a little bit of confusion. Anu's superb skills. There was one follow-up question which came regarding the diagonal, but I think the answer was to leave it alone. It had excellent flow from what I had noticed.
Yep.
Yes.
Anu, just any concluding comments? Again, I think the high point of the case was identifying that you were in a subintimal course, coming back proximally, redirecting and crossing with the Gaia. Was anything else you would like to add?
No, I think overall the wires we have discussed, the escalation, the same thing. I think what you need to do is have at least 3 group of wires in your lab. You don't have to have every wire that is out there, and be comfortable with these 3 groups of wire. And then, you know, keep doing a couple of cases. You'll get used to them and just use them in every other case, which we have shown here now.
Congratulations on an outstanding case. We are going to conclude here and see you on April the 21st.